Thanks, Dr. Silver. And I'm going to talk about a group of diseases which may in fact be zebras or more esoteric to this audience, but I hope this will be fairly educational. So first of all, let's pivot to the 2016 WHO classification of myeloid neoplasms. And I've highlighted in green and red font the diseases that we're going to talk about today. First of all, chronic eosinophilic leukemia not otherwise specified. And then a laborious title of myeloid/lymphoid neoplasms associated with eosinophilia and abnormalities of platelet-derived growth factor receptor alpha, PDGFRB, fibroblast growth factor receptor 1, or PCM1 JAK2. And I'll also talk about who defined myeloid neoplasms that are associated with eosinophilia, for example, such as MDS or mastocytosis, and also touch on hypereosinophilic syndrome. So I think this slide is a useful algorithm for how one approaches the diagnostic workup of hypereosinophililia. The first thing that I do is screen for secondary causes because, frankly, the overwhelming majority of individuals who present with eosinophilia will have a secondary cause. If one is found, and I'm not going to annotate all the secondary causes, then you treat the reactive eosinophilia. I'll just mention that in third world countries, the major cause is helminth infections or some type of infection. And in Western developed countries, it's atopy or allergy. If the workup for reactive eosinophilia is negative, then the first thing I do is screen the peripheral blood for the FIP1L1-PDGFRA fusion by FISH or PCR, or I look at standard site genetics for abnormalities that infer involvement of one of the genes that I referred to. So 4q12 for PDGFR alpha, 5q31 to q33 for PDGFR beta, AP11 for FGFR1, or 9p24 for JAK2. And if you find one of those, then the patients will be geared toward the appropriate treatment. If patients are negative for any of these translocations, then I look for a who-defined myeloid neoplasm associated with eosinophilia like SM or MDS. If that does not exist, then I look at the bone marrow peripheral blood to see if there are increased blasts or another molecular cytogenetic abnormality, in which case the patient may meet criteria for chronic eosinophilic leukemia not otherwise specified. If that is not present, then I'll look for an abnormal clone of T cells, either by PCR or by flow, and we refer to those patients as lymphocyte variant hypereosinophilia. And if that does not exist, then we're left with patients with idiopathic hypereosinophilia if organ damage is not present, and idiopathic hypereosinophilic syndrome, or HES, if organ damage is present. So this is what I use for the diagnostic evaluation of eosinophilia on the peripheral blood. Of course, the first rule is looking at the smear with your CBC. Chemistries, because of vitamin B12 level or LDH can be elevated. Serum tryptase level, because it is often elevated in myeloproliferative variants of eosinophilia. If the IgE level is elevated, that might indicate atopy or allergy. Now, that FIP1L1-PDGFRA alpha is not visible by standard site genetics, so you need to do FISH or RT-PCR. And then other molecular tests such as, of course, BCR-ABL1, JAK2 or KIT, and myeloid gene sequencing by next-generation sequencing. The bone marrow is important, looking, of course, at histopathology, standard site genetics, flow, and again, myeloid mutation panels. And then, of course, eosinophils can cause organ damage. So it is important to look at the organs. The heart is a particular organ that suffers damage for patients that have severe eosinophilia of long duration, so an echo or cardiac MRI. Using ultrasound CT or MRI to look at the abdomen and pelvis for organomegaly, endoscopy looking for bowel involvement, and also organ-directed biopsy if it's felt to be clinically needed. Now, there's one thing that I stress with fellows and frankly other faculty and community docs, and that is you need to know your breakpoints by standard karyotyping. If you don't, you're going to miss opportunities perhaps for targeted therapy. Not to say that targeted therapy in all cases is going to be a magic bullet, but it might provide a potential bridge to more intensive therapy or transplant. So 4q12 is where PDGFR alpha is located. 5q31 to q33 is where PDGFR beta is located. Of course, you know that ABL is located at 9q34. FGFR1 is located at AP11, hint, hint, pre-audience survey question. JAK2 is located at 9p24 and FLT3 at 13q12. So whenever I have a patient with eosinophilia, we do a bone marrow biopsy, we look at cytogenetics, I'm always looking for these breakpoints. Now let's go back to 2003, and this is the year that the FIP1L1-PDGFRA alpha fusion was discovered in patients who were provisionally categorized as hypereosinophilic syndrome. And this is a interstitial chromosome deletion on chromosome 4q12. The deletion is some 800 kilobases that is on just one segment of 4q12, and it brings together the FIP1L1 and PDGFRA alpha genes. And you can see that in the middle there's a gene called CHIK2. And so one can perform, and this is what's mostly available in laboratories, a test called FISH for the CHIK2 deletion. Why? Because when you bring these two genes together, you delete the segment in between, including the CHIK2 gene. So FISH for CHIK2 deletion is a test that most people use to detect the fusion. Again, not detectable by standard cytogenetics. And this is a bone marrow that's actually from the patient that's in the article. It's a patient that Dr. Stan Schreier and I treated back in 2002. You can see that before imatinib treatment, the bone marrow is very hypercellular with marked fibrosis, and there are actually increased blasts. The patient actually had acute leukemia arising from hypereosinophilic syndrome. And so increased blasts and eosinophils. And we did a bone marrow after 3 months, after the patient was already in a complete hematologic remission. And the first time we did the bone marrow, we thought it was a sampling problem because it was completely cleaned out, but we went on the other hip. In fact, that's exactly what we saw. The disease was completely cleaned out with Gleevec. So let's step forward a decade and really summarize what we learned about FIP1L1-PDGFRA alpha positive myeloid neoplasms. Well, it's interesting because in that first NEJM article, the percentage of people that, or patients in that article that had the fusion was 56%. But it's important to note that it was a highly selected group of individuals who had been through multiple lines of therapy and had a myeloproliferative variant of eosinophilia. But if you just take patients with idiopathic hypereosinophilia that present in your clinic, really it's less than 10% of individuals that will have this fusion, so actually quite uncommon. These patients are overwhelmingly male. In fact, it's very hard to find a female that has this disease. And in 2016, either biologically, from a molecular, hormonal, or metabolic standpoint, we don't understand why basically all patients are male. Again, not visible by standard cytogenetics. Most people use FISH to detect it. It's associated with increased tryptase levels or vitamin B12 levels, although, of course, those are nonspecific, and of course, you should look for this abnormality by using FISH if available, but they can be useful surrogates. This is referred to as a myeloproliferative variant of hypereosinophilia. The bone marrow typically does show increased fibrosis or sometimes atypical mast cells, splenomegaly, anemia, thrombocytopenia are not uncommonly present, and very rarely it actually can present as acute myeloid leukemia with eosinophilia. This is a disease that we found out is exquisitely sensitive to imatinib at lower doses of 100 milligrams per day. You do not need 400 milligrams per day. Relapses are very rarely observed. There's probably only about 10 to 15 case reports in the literature. And maintenance dosing of only 100 milligrams per week can actually keep patients in remission, and this is a POLIS study. So it's hard to believe that taking 100 milligrams a week of a drug can keep a disease in remission, but actually it appears that this is feasible in a major proportion of individuals. And again, there are rare cases of acquired resistance. Primary resistance is essentially unheard of. And then two mutations that come out are T674I, which is actually analogous to the T315I mutation that we find in patients with CML. That's the pan-resistant mutation to imatinib, nilotinib, and dasatinib. And the D816V mutation, again, usually found when the disease progresses. If you look at case series of this disease, you can see that CHR and CMRs, complete hematologic and complete molecular remissions, are very, very high, approaching basically 90 to 100%. And you can see that the number of cases of resistance or death are very low. However, if you get one of these two mutations, some would say that the ball game is over. I'm a little bit less pessimistic. What I would say is that these are mutations that have been seen in patients where alternative TKIs have been used, such as nilotinib, sorafenib, or dasatinib. Frankly, most of them do not work, and if they work very transiently, and most patients end up dying. And it's for that reason that these are individuals that need to be looked at for going to transplant, because that's the only modality that's going to salvage these individuals once they get these mutations. This is a schematic showing that there are core genes that are involved in fusions. And again, you can see that PDGFR-beta in the mid-left-hand corner of the slide has now some 25 fusion partners. FGFR1 has about 13 fusion partners. JAK2 has several fusion partners. PDGFR-alpha has about 7. And literally every few months, we have a case report in the literature of another partner that's fused to PDGFR-beta, PDGFR-alpha, FGFR1, or JAK2. So what do we know about PDGFR-beta rearranged neoplasms? Well, first of all, the first case was described by Golub and colleagues in 1994. Again, a lot more fusion partners have since been described. The phenotype or the clinical presentation of these individuals is one of an MDS-MPN overlap, usually CMML or atypical CML, with eosinophilia. But it's important to note that although eosinophilia is in the title of this major WHO category, eosinophilia is not invariably present. I have and others have had patients with these fusions that do not have eosinophilia, so it's important to take note. In some cases, patients present in the blast phases of myeloid disease or have concurrent B or T cell lymphoblastic leukemia. The diagnosis can be made by standard karyotyping by having a 5q31 to q33 breakpoint. And FISH can be used, or RT-PCR can be used to confirm the fusion with PDGFR-beta. Treatment is with 400 milligrams per day, and doses of 100 milligrams per day has been used as maintenance. And these patients generally have a very good long-term prognosis, with very few individuals experiencing resistance. So again, like the FIP1 PDGFR-alpha patients, imatinib does a job in most individuals. HFR1 rearranged neoplasms is a completely different story in terms of prognosis. So first described in 1985, again, about 13 fusion partners since. These patients presented with an MPN or AML, usually, but not always, with eosinophilia. And they can have both a myeloid disease and a B or T cell lymphoblastic leukemia or lymphoma. And we actually had a tri-lineage patient that had both B and T cell lymphoma and myeloid neoplasm. These are, again, patients that usually have a visible cytogenetic abnormality that involves a breakpoint 8p11 to 8p12. And patients, either at presentation or with evolution, usually actually have clonal evolution. We actually have a patient in House Hospital right now that actually has a RUNX1 translocation in addition to the 8p11 rearrangement. This is a disease that arises in a multipotent hematopoietic progenitor, and that's why these patients have both myeloid and lymphoid disease. And the clinical course is very aggressive, terminating in AML usually in only 1 to 2 years. Therapy is usually intensive AML or ALL induction chemotherapy followed by transplant. And there are small molecule inhibitors of FGFR1 in development. Ponatinib has some activity against the disease in basically case reports presented to date in the literature. So what about treatment? Well, this is a case series by Andreas Reiter's group out of Germany. And you can see out of this group of basically 7 individuals, chemotherapy with either hydrea or intensive chemotherapy did not provide durable remissions. Ponatinib at doses of 30 to 45 milligrams per day, because it has anti-FGFR1 activity, you do get some responses, but they're generally short-lived with really very few cytogenetic remissions. And you really need to, again, have these patients go to transplant, where the experience thus far, again with limited numbers of individuals, show that they can have durable disease-free survival and a chance for cure. So this is actually from a case report that we published in Leukemia last year. And again, this is that patient who had a BCR FGFR1 fusion that presented as acute myeloid leukemia with very bulky cervical, mediastinal, and paravertebral lymphadenopathy. And this is a patient that got pre-phase chemotherapy with Cytoxan, dexamethasone, didn't touch his lymphadenopathy, got MEK chemotherapy, counts dropped, but it didn't touch his bulky lymphadenopathy. And then we used ponatinib, a single agent therapy. And you can see before versus 1 month with ponatinib treatment, you can see here that you've got reduction in FDG-avid disease, basically in the head, neck, and paravertebral areas. So by no means did ponatinib alone do the job in terms of inducing a molecular cytogenetic remission, but you can see that there was single agent activity, at least by PET. This patient ended up getting hyper-CVAD with ponatinib. Then we stopped the ponatinib. The patient was in a complete morphologic remission with evidence of disease by FISH and by PCR. We sent the patient to transplant. And after transplant, he was doing well, but we actually had detection of the fusion transcript after transplant, so we added back ponatinib. You can see in the last two columns. And actually, at least by the semi-quantitative assay, we cannot detect the fusion transcript anymore. We have now used quantitative RT-PCR to detect the transcript. It's at very low levels, and the patient is now alive, coming October, 3 years after transplant, with no evidence of morphologic disease. He's doing well, and he remains on ponatinib at 30 milligrams per day. And I have to admit, I was a little bit concerned about using ponatinib off-label because all the issues of the cardiovascular issues related to the drug, but he is doing well 3 years out, and I hope this is someone that we've cured. Now, what about other rearrangements? So what about those including JAK2? Well, again, Andreas Reuter's group has used Ruxolitinib to target these JAK2 rearrangements. And you can see that in both these cases where there's a PCM1 JAK2 or BCR JAK2 fusion, that you get a hematologic response. You actually can get a complete cytogenetic remission, but it's short-lived. And in fact, these are patients that ultimately likely need to go to transplant to induce a long-term disease-free survival. So I consider the use of ruxolitinib in such individuals as something that might be able to subtly reduce a disease, but also really only as a bridge to transplant. Okay, now we're moving away from the rearrangements associated with eosinophilia to those who defined myeloid neoplasms associated with eosinophilia. And these are entities that I think the audience is very familiar with. So AML with recurrent genetic abnormalities, such as by FAB, the M4EO. CML, of course, is well known to be associated with eosinophilia and basophilia, MDS, other MPNs, mast cell disease, and of course MDS-MPN overlap syndromes, including CMML and atypical CML. One may ask, what is the prognostic relevance of eosinophilia in these disease contexts? There has been a study in MDS where those patients with MDS with associated eosinophilia or basophilia have been shown to have a worse prognosis. In mastocytosis, the presence of eosinophilia seems to be prognostically neutral. Now, this entity here, lymphocyte variant hypereosinophilia, of course, is not a myeloid neoplasm, which is the title of the talk, but I think it's just worth going over it briefly. First of all, this is an entity that's not even formally given any worth in the WHO, and it doesn't have any diagnostic consensus, any consensus diagnostic criteria. We think it's related to the clonal expansion of abnormal T lymphs, and these are T lymphs that are CD3 positive or CD4 and CD8 negative, or CD3 negative and CD4 positive, so they're clearly abnormal T cells. These T cells can be detected by flow or T cell receptor gene rearrangement. We believe that these T cells secrete high levels of eosinophilic cytokines such as IL-5 or GM-CSF or IL-3. Clinically, these patients present with skin symptoms and usually a benign course, but there are patients who rarely evolve to T-cell lymphoma or Sézary syndrome. So you see the schematic below. This is really a mixture of a reactive and clonal disease where you have clonal T cells that are elaborating eosinophilic cytokines that in turn cause the increased production of eosinophils from the bone marrow. Now, I can tell you personally, my feeling is that detecting a T cell clone in the presence of eosinophilia is fairly useless. We see T cell clones in almost everything, including infection and inflammation. So it's my opinion that it's more useful to find actually a flow profile, such I've shown there below in the lower left-hand corner, associated with eosinophilia that might be more provocative in making this diagnosis. You can also make this diagnosis if you've got someone who's doing research studies where you're putting T cells in a in vitro culture, collecting the supernatant and finding high levels of IL-5 or IL-3 or GM-CSF, but of course, no one's going to be doing that, and it's not clinically practical. Now, what about another entity, chronic eosinophilic leukemia not otherwise specified? These are patients that don't have a PDGFR alpha, PDGFR beta, FGFR1 rearrangement, or PCM1 JAK2. They have nonspecific increase in blast or some nonspecific cytogenetic molecular abnormality. For example, the cytogenetic-wise trisomy 8 or isochromosome 17, in terms of molecular mutations, JAK2 has been found in some patients. There is one study that found this KIT M541L variant in 4 out of 5 cases with chronic eosinophilic leukemia. And in this study, they said that this variant was somatic. That is, they looked at CD3 positive T cells, they looked at skin cells, and they did not find the variant. They thus defined it as somatic. The only problem is that this is a well-known polymorphism or germline variant, so it's not clear whether this variant is actually associated with driving the disease. Having said that, when they used imatinib in these individuals, these cases were very sensitive and these patients achieved a hematologic remission. Overall, when you look at the prognosis of these patients, it's generally poor. In one series of 10 patients, the median survival was short of 2 years. 5 patients developed acute leukemia after a median of 20 months. 3 of 5 patients otherwise died of active disease, and there were a couple of patients that achieved longer-term disease-free survival with transplant or imatinib or hydroxyurea. But overall, a poor prognosis. Now, again, we've gone through several entities. We've gone through those patients that have eosinophilia with rearrangements, that have a myeloid neoplasm associated with eosinophilia, that have CEL and OS, who may have a lymphocyte variant of the disease. If you don't have any of those and you have organ damage, then you're left with a diagnosis of idiopathic HES. But it's very fair to say that over the last 20 to 30 years, as we've defined more molecular and cytogenetic abnormalities, the pool of patients with HES is shrinking. Now, there are a couple of studies that are worth mentioning here in terms of what we have found in patients that have been previously alluded to as HES. This was a study done by, again, Andreas Reiter and colleagues, where 426 patients were referred for hypereosinophilia to be tested for the FIP1L1-PDGFRA alpha fusion. Well, they found the fusion in 12% of patients. They actually also used next-generation sequencing to identify other mutations, including JAK2 V617F and KIT D816V. And those 14 patients, or 3% that had KIT D816V, when they further looked at the bone marrows, these patients actually had systemic mastocytosis. And if you look at the Kaplan-Meier curves for survival, you can see that the survival of those patients with FIP1L1-PDGFRA alpha disease is very good because these patients are treated with imatinib and live very long, whereas the survival of those patients with a KIT or JAK2 mutation is relatively shorter. And this is a little bit busy, but in terms of the clinical laboratory presentations of these individuals, patients with KIT2 or JAK2-driven eosinophilia are older compared to those with the FIP1L1 fusion. The patients with the FIP1L1 fusion, as I mentioned, are overwhelmingly male. You can see here out of 55 patients, 54 were male. You can see that the absolute eosinophilia is markedly higher in those with the FIP1L1 fusion. And you can see that the tryptase levels, very high tryptase levels, segregate with those patients that have systemic mastocytosis with the KIT mutation. Now, this is another study that looked at patients with HES who underwent next-generation sequencing. These were 51 patients, and you can see that out of the 51 patients, 14 or 28% were found to have one or more mutations in typical myeloid genes, such as ASXL1, TET2, EZH2, SEPP1, SIBL, and NOTCH1. And when they looked at the survival of those patients, HES that were positive for mutations or negative for mutations, compared to them to CEL and OS, those HES patients that were found to have mutations actually had a survival that approached that of chronic eosinophilic leukemia. That is, the survival was poor. In contrast, those patients that have HES in which no mutations were found, the survival was relatively better. So this is just another example how if you have a patient with HES, there may be value in doing next-generation sequencing because you may find a druggable target, but also you may get a little bit more traction about what the prognosis of those individuals is. And then we have here a table about, again, the tyrosine kinases and the fusions and the potential for targeted therapy. You can see that if you have a PDGFR alpha or PDGFR beta fusion, that imatinib can be very useful. The utility of ponatinib, ruxolitinib, or sorafenib for the other rearranged genes is less compelling, again, maybe perhaps as a bridge to transplant. I show the slide because there are patients with mastocytosis with eosinophilia in which we've used midostaurin, which is a multi-kinase/KIT inhibitor. And this is a drug that, at least in patients with eosinophilia associated with mast cell disease, the drug really drops the eosinophil count like a stone. I've referred to this kind of as an EO killer in these particular individuals. And we've had patients where the eosinophilia has remained basically to normal levels for 4 to 5 years with continual use of this agent. So just wrapping up, what are the other options for different subtypes of hypereosinophilia? Again, if you have a WHO-defined myeloid neoplasm such as MDS or CML, you want to, of course, treat the underlying neoplasm with the conventional drugs that are available. If you have CEL and OS, it's really dealer's choice. You can use hydroxyurea, pegylated interferon alpha, and imatinib may be useful, but you really want to see if there's a target. Otherwise, I don't think it's particularly effective. Allogeneic transplant or always consideration of a clinical trial. For lymphocyte variant disease, really the mainstay of treatment is either steroids or on a compassionate use basis, the use of an anti-IL-5 antibody such as mepolizumab. Mepolizumab is actually approved right now just for eosinophilic asthma, but not for HES or lymphocyte variant disease. And finally, for HES, steroids, hydrea, interferon, imatinib, again, mepolizumab, or consideration of transplant or clinical trial. And then just looking at antibody forms of therapy, I mentioned mepolizumab, which is an anti-IL-5 antibody. There's actually an antibody now in development that Amy Cleon at the NIH is trialing, which has been benralizumab, which is an antibody against the receptor for IL-5, not against IL-5 itself. CD52 is expressed in eosinophils, so there may be a role for alemtuzumab or Campath. There's a drug called there's a drug called SL401 that's actually an interleukin-3 receptor alpha antibody linked to diphtheria toxin, and this is in trials right now at multiple centers in the United States. And there are actually agonists that are against the inhibitory receptors for eosinophils, such as against cyclic 8, and these are going to probably enter trials in the next couple of years. So just to summarize what I've indicated today, standard karyotyping and targeted molecular analysis are really critical to identifying the subtype of the eosinophilic disorder. Eosinophilia is a very common but not invariable feature of PDGFR alpha, beta, FGFR1, or JAK2 rearranged disease. The prognosis of these disorders with eosinophilia are variable depending on the rearrangement, and we need to consider TKIs, chemotherapy, allogeneic transplant, depending on the subtype. And I do think this is a group of diseases where next-generation sequencing could be useful, and again, to help with prognosis to see if we can find an actionable target. So I'll stop there, and after this session today, I'll be glad to answer any questions. Thank you very much.